Yes, welcome everyone. Any loitering people outside the door if you want to come in? Nope. Okay, so welcome everyone to this next session, which I think is going to be really interesting. I'm going to have each speaker come up in turn, and then we'll do Q&A at the end of it. Okay, so if I could first of all welcome Fiona Moffat up to the stage or to the platform. Would you like to introduce your title?
I would indeed. Good afternoon, and thank you for joining this session. My name is Fiona Moffat, and I'll be presenting research on behalf of the Restart study team. And the title of my presentation is My Bloody Leg, the lived experience of arthroplasty and manipulation under anaesthetic following total knee arthroplasty. So what do we know? Well, we know that total knee arthroplasty or knee replacement is a common and cost-effective intervention for end-stage OA knee. And analyses predict that we will continue to see a sustained growth in this type of intervention globally. And yet not all experience a favourable outcome. Research suggests that arthrofibrosis, or the proliferation of fibrous tissue in and around the joint, affects somewhere between 1.3 and 19.8% of patients who undergo knee replacement. And clearly this has a significant economic burden. But to date, to our knowledge, no studies have explored the lived experience of arthrofibrosis, and therefore our objective was to fill this gap in the evidence, as we believe this was critical to the development of future rehabilitation interventions. So I'd just like to take a moment to situate this study. It is part of a larger NIHR-funded study aiming to develop an optimal intervention for patients who experience arthrofibrosis post-knee replacement. The work I am presenting to you today is part of work package 2. And the aim of this work package specifically is to determine the lived experiences, important outcomes, and unmet needs of those patients who experience arthrofibrosis. So what did we do? We used semi-structured interviews to gather in-depth and rich data from people who had undergone elective total knee replacement and who'd experienced post-op arthrofibrosis and manipulation under anaesthetic, or MUA, in the last 12 months. Our participants were recruited purposively from 3 NHS orthopaedic units in the East Midlands, and our data was transcribed verbatim and subject to thematic analysis. What did we find? Well, we recruited 14 participants with an equal mix of those identifying as male and female. Our age range was 56 to 82 years with a mean of 68. As you can see, we did well in terms of our occupational status, so we had a nice diverse range there. But unfortunately, we were much more limited in recruiting from a diverse ethnic background. We developed 5 themes, and I'm going to discuss each of these in turn. So the first theme was the biopsychosocial impact of arthrofibrosis. Participants provided this really rich account of the impact that pain and stiffness had on their physical function. Most daily activities were frustratingly affected, hence the title, quote, My Bloody Leg. For many, the consequences were so significant that individuals identified as disabled, older than their years, or abnormal. For some patients, the extent of disability was all-encompassing, and one participant described the situation as, "It's ruined my life." A form of cognitive dissonance was evident, with patients really struggling to reconcile what they felt they should be able to do with the reality of what they could actually achieve. And the functional limitations experienced by our participants had a concomitant and overwhelming effect on their social functioning, Most described some sort of downturn in their social participation and an associated impact on their mental health, with some becoming clearly very depressed. And 2 participants gave really graphic accounts of the vulnerability they felt as a result of their condition, becoming fearful of going outside alone or being left at home alone. The second theme centred around participants' experiences of communicating with healthcare professionals. So participants noted varied experiences, and whilst most felt that they'd been really well informed in the run-up to a knee replacement, once arthropibrosis was established, communication was often described as minimal, somewhat vague, and lacking holistic and person-centred approaches. And participants described this real need for conversations that offered time. And to discuss the ability to discuss their concerns and what the future might look like for them. And value-added activities were often recommended. So things like regular check-ins so that people didn't feel dismissed or discarded. A really key concern for many of the participants was the perceived inconsistency in advice about functional activity, but also about the intensity and type of exercise they were expected to do. And this inconsistency in advice made it really difficult for patients to strike a balance between doing too much or doing too little. An exemplar quote is on the screen. Now they've just given me another physio who said to me, for goodness sake, use the crutch to support you. If you feel like you're going to go when you walk in, just use it. Then you go to another physio and they say, you don't need it, and things like that. That's what gets me. One doesn't know what the other one is doing. The third theme related to sense making. So participants described various stages of realization. For some, that seemed to happen in the early post-op period when they said it just didn't feel right. But for the majority, the realization was much more insidious when they noticed that their rehab had simply come to a standstill. And individuals invested really significant time and in some instances real emotional labour in their quest for understanding what was happening to them. Most understood that stiffness was a result of the scar tissue, but again, most questioned whether there were other rationale or causes as well. And in an effort to make sense of their experience, unsurprisingly, participants sought information from multiple sources, including, of course, Dr. Google and other patients who'd experienced knee replacement. And once again, there was this commentary about an apparent discrepancy between the information available prior to the knee replacement as compared to the management of arthropibrosis. And a number of individuals demonstrated some resigned acceptance of their situation. They do say you sail through hips but struggle through knees. Many, however, were left angry and frustrated and with decisional regret. The penultimate theme related to commitment to exercise. So all participants indicated their awareness for intensive rehabilitation in the early post-operative period. And they described at great length the exercise programs that they had engaged in at home. And many indicated their commitment, as you can see on the screen here. Some had independently sought alternative approaches to exercise rehab, including swimming and aquatic exercise and attendance at private gyms. But access to preferred facilities was problematic for some. Interestingly, there was limited awareness of the options for adjunctive treatments, and bracing and splinting were infrequently discussed. The final theme is nothing to lose. This relates to the decision to proceed to MUA. Once realisation had occurred, participants were largely pragmatic about MUA. The procedure was viewed as a last hope to resolve their issues. Some remained reserved about the likelihood of success, but acknowledged that they were prepared to take the gamble. Unfortunately, the majority did not attain the outcomes that they had wished for, leading to disillusionment and yet further distress. And I'll wrap up now. So in terms of the conclusions, the experience of arthropfibrosis is one that's characterized by distress, confusion, and frustration. We know that many experience these inconsistencies, which leaves them onto a quest for understanding, but yet despite this, they remain committed to their exercise program. In terms of how this will inform our intervention, we know that it's important that we acknowledge the acutely sensitive or significant impact on the biopsychosocial model, on the biopsychosocial impact of the condition. We need to ensure that future pathways and interventions are consistent and clear in the information they give. And finally, we would propose that some form of decision support or a patient decision-making tool is warranted to support active patient involvement and improve the rehab experience, given the patient's desire for information, choice, and having their needs valued. Those are my references. I'd just like to acknowledge the NIHR and the rest of our study team, and thank you to you all for attending.
Thank you. So if I can invite Melanie Narsami up to the front.
Good afternoon, everyone. Good to be here with you today, and good to follow on from Fiona's presentation as well. So I'm going to present from the same research study, but I'm going to be focusing on the healthcare professional data. So just to put in context why we wanted to speak with healthcare professionals, total knee replacement is an effective treatment for those with severe osteoarthritis, but a portion of those surgeries can lead to complications such as severe knee stiffness or arthropfibrosis. Now, we know that physiotherapy is the recommended first-line treatment for this severe knee stiffness, but there's very little in the way of standardized guidelines, so we don't really know much about what's delivered. There's very much wide variation in what's delivered by healthcare professionals. Now, some who do have this severe knee stiffness go on to have a manipulation under anaesthetic procedure, or an MUA. But the problem is that can lead to complications in itself. It's not always guaranteed to be effective. So there's very much cost to the individual, cost to the NHS, and cost to the economy as well. So if we can provide better direction as to what that first-line physiotherapy should include, then that's obviously a favourable situation. So in terms of our research design, the overall aim of the Restart study was to develop a protocol for an optimal physiotherapy intervention. Now, specifically, we wanted to speak to our healthcare professionals because we wanted to know more about the current context. So we wanted to know about the barriers and facilitators to providing effective management for that condition. So we were very much interested in speaking with healthcare professionals with at least 5 years experience of dealing with post-total knee replacement patients or post-TKR patients who'd experienced that severe knee stiffness. In the case of surgeons, we were interested in recruiting those with at least 3 years experience. So we used purposive sampling techniques in orthopaedic units in England, and we also shared our study information with our professional networks. As a result of that, we ended up recruiting 11 healthcare professionals, so 5 physiotherapists, 5 surgeons, and 1 occupational therapist. We did semi-structured interviews with those participants, and we subjected that data to a thematic analysis. I will just mention at this point that I myself am not from a clinical background. I'm a health researcher from a social sciences background, but our research team did encompass clinical academics. So you'll see from the next slide the timeline for those research activities. And if you look at the 4th box, you'll see that we spent quite a lot of time doing our data analysis whilst concurrently trying to develop this intervention. So as we were getting our healthcare professional data in, we were extracting key factors from that data that we felt were important to consider for the intervention, because we wanted to make sure that the intervention was workable for healthcare professionals as well as being suitable for our patients. So the area of findings I'm going to talk to you today about is what our healthcare professionals perceived as the barriers to effective care and treatment for this patient group. So you'll see that the barriers really fell into 4 categories. We've got system issues, where our healthcare professionals described what it was like working within the pressures of the NHS and the impact that was having on communication between staff and also patient access to physiotherapy. Also, healthcare professionals described that this severe knee stiffness was a very complex phenomenon. So sometimes that meant that there were gaps in knowledge, mainly because understandings about how to effectively manage this condition have only just recently been emerging. Healthcare professionals also provided insight into patient factors, including why patients perhaps don't always engage in physiotherapy exercise regimes. And they also spoke about their difficulties in knowing when to propose certain interventions to deal with severe knee stiffness as well. So I'm going to show you some data around those issues in the next few slides. So we'll start with system issues. So one of the things that healthcare professionals were concerned about was that patients were not universally getting equal access to good physiotherapy. So there was some acknowledgement that the COVID-19 pandemic had played a part in that. So face-to-face appointments were being reduced, a lot of sessions were being conducted remotely. And healthcare professionals suggested that that made patients sometimes feel like they hadn't had the physiotherapy input. Also, they described there being a postcode lottery where different trusts and different areas were offering different things. So sometimes the expertise and specific interventions were only available in certain locations. So patients didn't always have the same options. And healthcare professionals very much spoke about the impact that was having on patients. So this surgeon says that in the NHS, there's a lot of disappointment around the provision of physiotherapy. Patients sometimes feel they've been abandoned. So that's quite a powerful description as to the impact on patients. In terms of identifying the problem of severe knee stiffness, sometimes there was a conflict for healthcare professionals. They didn't want to go in too early and kind of diagnose severe knee stiffness when it was just perhaps normal stiffness post TKR. So distinguishing between that could be tricky sometimes. Sometimes healthcare professionals also said that they struggled with interpreting range of motion, suggesting that that was a gap in knowledge. This physiotherapist talks about a scenario where a patient is stuck between that 50 to 60 degree range of motion. And, knowing the points, after how many weeks should I be concerned and start thinking about maybe some more intense interventions. However, some healthcare professionals we spoke to, although they said that there isn't like a standardized protocol that they use, they did describe some of the steps that they take to try and diagnose severe knee stiffness, and what they described what they would do, to follow on from that. So this physiotherapist talks about being patient-led, so starting with the patient first, and then working on there to do an objective assessment to kind of, follow, know what the next steps would be to that. Also, we did hear some really interesting things from Fiona's data, but healthcare professionals also spoke about the reasons why they thought patients were not engaging always in their physiotherapy exercise. So one of the key issues was fear. So healthcare professionals noted that patients were sometimes frightened to move the knee after the knee replacement surgery because they didn't want to inflict damage, and sometimes that fear was heightened if there was a pain factor as well. Also, because of the nature of self-directed physiotherapy, it meant that healthcare professionals felt that they didn't have as much opportunity to monitor patients. They were effectively waiting for patients to come to them and kind of report any problems, and sometimes that didn't happen if the patient wasn't aware that there was a problem. Also, this is a really important quote from the physio who says that, if a patient is post-TKR, they've got reduced mobility. So practically, it might be quite difficult for them to come in to appointments. So part of the assessment should be how easy is it for them to actually come in and attend their physio appointments, and support needs to be given to them around that. And also in areas where specific interventions such as the stack tool were being used, healthcare professionals suggested that you know, that could be quite onerous for patients in terms of the time commitment and what's expected of them. I won't go through this slide because I know that time is creeping upon me. I just want to finish off by showing some of the things that we took from the healthcare professional data to consider for the intervention. So the value of face-to-face sessions. Obviously, face-to-face sessions gives healthcare professionals the chance to monitor and supervise patients whilst also helping patients to feel that they've had some physiotherapy input. Also, we know how important education and advice is in the healthcare professional role. We know that healthcare professionals do a really good job, you know, incorporating those things in their practice. But just around that, there is a need to provide patients with typical recovery timeframes for range of movement, and that needs to be shared across the healthcare team so that everybody's on the same page with that. Also, pain needs to be, the issue of pain needs to be sensitively managed. So patients need to be advised what to expect during and after exercises. And crucially, there also needs to be a clear standardized system to help healthcare professionals monitor patient symptoms and to enable them to then propose exercises accordingly. So that concludes the presentation. Thank you so much for listening. Please do take a look at those acknowledgements. Those are the people who've made the study happen, including our participants. Thank you to the CSP for the opportunity to present today. I've got my contact details there should you want to get in touch. Thank you.
Thank you very much. Thank you. So if I can invite Karen Barker. I have to read I haven't got my glasses on. Yes.
Hi, thank you for inviting me this afternoon. I'm really presenting the work of Ben Whedon. So he's done all of the work associated with this presentation, but he's having to work properly today, so I'm here to present it instead. So I'm not going to go into this in great detail, but we know there's a lot of knee replacements that are done every year. We know that a number of them, 6.7%, don't indicate that they've improved. And we don't really know in advance how to tell who's going to do well, who's not going to do so well. So if we had a way of predicting who might fall into that sort of 7% who are going to do poorly, then we might be able to target interventions to get a better outcome. The NICE guidance very helpfully says that knee operations are good, that most people will do well afterwards, and they do. And then it helpfully says that there'll be a subgroup of people who will need to have supervised rehab, not just self-directed, and notes that it'd be helpful if there was a tool to be able to predict who those people would be, but it doesn't offer anything about how you're going to predict them. So what we wanted to do was to take data which we had collected in a very large RCT we had done a few years ago, and just look about whether there were simple physical performance tests that were measured before knee arthroplasty that would help to predict this. And this was not data that was collected just for research purposes. There were things that we collected as a standard in our pre-op clinics. And then we thought from that we could see whether there was a subgroup of people who were at risk of a poorer outcome. So it's secondary analysis from the Corker trial. The Corker trial was looking at hospital-based rehab versus community-based rehab by physio assistants, and effectively showed on that both did well. For the purposes of this, we've combined both the groups, and we're looking at predictors of a figure-of-8 walk test, 30 seconds sit to stand, single leg balance, and then the physical activity scale for the elderly. And the thing that we were measuring it against, which was the primary outcome for the Corker trial, was the late life function and disability instrument, which some of you may not be so familiar with that. That's a questionnaire which really tries to look at both function and disability in community dwelling older adults. So really what are mostly the knee replacement population. So primary outcome, LLFDI. And it's important, we're trying to really map this to the sort of different things within the ICF model. So we're looking at function, i.e. the limitation to a person's ability to do different actions, and then the amount of disability that they were getting from their condition. So both in terms of how much it limited them from doing things in terms of the frequency of it, or how much it limited them by other factors like environmental factors or mental energy or accessibility or sort of socioeconomic things. So we measured them all at baseline, and then we had data available at 6 months, 12 months and 24 months. For the first trial, 12 months was our sort of primary outcome cut point. So Ben, did lots of multiple linear regression to assess the significance of the predictor variables on each outcome, and then adjusted for age, for sex, for BMI, and also by the recruitment sites. We had 621 people, average age of 70, really good data. So we had data on 619 of them, so only lost 2. And they were from 14 physio sites up and down the country. So from Newcastle to sort of Torquay, so lots of travelling involved. So what did we find? We looked at how predictive each of these factors was in terms of the LLFDI. We looked at it in the short term. By short term, we were looking at 6 months, and then we looked at it at 12 and 24 months. And what we can see is that single leg stance at 6 months and at 2 years was the most predictive thing for function. There's a little bit of a slightly different bit at 12 months where the sit to stand also showed some degree of predictive worth. Disability frequency, again, we can see that there were factors which was mostly the PACE questionnaire, which was predictive of how much disability there would be in terms of how often it would impact on you. And then disability limitation, again, in the long term, the PACE and the single leg stance test were the things that were proven to be predictive. So what do we conclude from this? So I think we conclude if you're going to just do one measure which may help you work out who is going to do less well after knee replacement, then a 30-second single leg stand test is probably going to be helpful. It's got really good clinical utility. You know, however busy you are, it doesn't take much effort to just get somebody standing on one leg for 30 seconds and seeing how they can do it. So really easy to implement in a standard pre-surgery exam. And, we do this just on the morning they come in for surgery. So, a same day admission, we just literally do it first thing in the morning before they go up there and then record it. So we felt that had good clinical utility and good predictive value, certainly as good as a lot of more complicated tests we could use. And then the physical activity questionnaire, again, we felt was very important for predicting function in both the short and the long term. And we liked it because it was very quick and easy to complete. It takes even quite a slow patient who has to get their glasses out and who's not great at reading, they can do it in less than 5 minutes. It's targeted at the elderly, and it only relies on very short-term recall. So there are very few people who can't complete that questionnaire. And we felt that that could be important in predicting both short-term and long-term disability. Obviously, with any study, there are limitations, and this was using data which was not designed as the whole trial was not designed for seeing could we predict who would do poorly. We were looking at whether 2 different treatment interventions were equivalent. You could say that if we'd measured physical activity far more robustly with more onerous physical tasks, or if we'd measured the self-report physical activity by something like the IPAC, then it might have been more robust. They were deliberately pragmatic, quick and easy, good clinical utility tests that we used, but it still came out as helpful in terms of the predictive function. And then, as with all these things, we've shown that it was statistically significant. It is questionable how clinically significant it is, but we need to do some sort of further work to look at the clinical significance as well as the statistical significance. Just like to thank the NIHR, who funded the original Corker programme, the Oxford Biomedical Research Centre, who provided some support for doing the secondary analysis, and to colleagues for doing most of the work. I just have presented it. So thank you.
Thank you. And if I could invite David Hamilton to come up. Thank you.
Right, afternoon. This is hopefully a nice little short paper from my group in Glasgow and some clinical colleagues over in Edinburgh. So we're going back to the start of NEOA and we're thinking about primary care management. And this, not working. There we go, apologies. So there are various things we can do for knee osteoarthritis. Things have come and gone over time. Those of us that have practiced in this area for 20 years will have seen different emphasis in different modalities. And we have recent NICE guidelines, relatively recent NICE guidelines, focusing on sort of core strategies. But this little piece of work came from an observation from clinicians that patients came in with different levels of information and desires for particular interventions. And we were wondering where they got their information from. And it wasn't just Dr. Google. It was that when you look, different guidelines seem to say different things. This is very simply a review of the international clinical practice guidelines for knee osteoarthritis. It's not very easy to give you a short presentation explaining a systematic review. It's not very exciting. We did a reasonably good review. We did the full Prisma search methodology. We screened over 750 articles and the International Guideline Network. Ultimately, we found 13 currently active clinical practice guidelines from across the world, from Asia, from Australia, from North America, from Europe, and obviously we included NICE, and other groups like OWARSI and rheumatological groups as well have different consensus-based guidelines, and that's the key. The quality of all 13 guidelines was actually really quite high. A lot of people, these are all active within the last 10 years, say, and they've not been updated. So everyone's looked at the literature. A massive systematic review has been done, Cochrane style, where fellows have gone, screened the literature, graded the quality of evidence, presented that to a sort of a panel of the great and the good. And the panel have decided how they weight that evidence to form their guidelines. Different panels are constituted, I think is the word, of different bodies. So you have surgeons on that, you have physios on that, you have anaesthetists on that, and various other professional representatives, shall we say. This is the snapshot. It's quite messy. There's 13 guidelines and they report a range of things. So think of it as a kind of heat map as to good, bad, we don't know, using a sort of traffic light system. So I'm going to change up the slide and try and talk you through overview summary. Quite literally overview. This is just the number of guidelines that agreed with this thing. So we have grouped the recommendations by theme in the sort of blue column, and the proportion of the 13 guidelines that said yes, definitely, no, definitely not, or not quite sure in the middle. So that's what these columns here are. So ultimately, as you'd expect, exercise, advice, self-management, weight loss, on the whole, were consistently agreed by all these bodies. Yes, that is the core management of knee osteoarthritis. Interestingly, not perfect agreement, only exercise was agreed in all 13 guidelines. Within this group in the middle, where we have things that look a bit like exercise, Tai Chi, yoga, CBT, where if you look at the group there, there's a lot of recommendations for, and some probably yes, and loads just didn't mention it in their guideline at all. We then have a group here of maybe yes, some say no. Manual therapy, acupuncture, TENS, thermos or cold and heat therapies, acupuncture, electrotherapies of any description. And then we have a really weird group at the bottom, braces, footwear, taping, orthotics, manual adjuncts, where we have yes, no, and I don't know. So a really, really strange mashup of advice. The interesting thing, and the only point of this short talk actually, is that 13 different clinical practice guidelines made the recommendations based on the same evidence. They graded the quality of evidence and they interpreted it. So this variation is due to us not deciding if we believe that evidence has good enough quality to make a positive recommendation or a negative recommendation. So great example being TENS. NICE is now saying, no, we don't think TENS is going to work. There's enough evidence, it's just not going to work. Others disagree. So we're going to follow NICE guidelines as a general rule in the UK, but our patients might not. So we have quite a lot of surprising inconsistency when we look across the learned bodies doing a good job but coming to totally opposite conclusions, particularly where the level of evidence is quite low. So the randomized trial evidence for braces and insoles and taping, as you might know, really has died a death, but in the sort of 90s and 2000s, there's quite a lot of bits and pieces. Modest quality trials, maybe a hint of something. How we interpret that very much determines whether we think it works or not. It's not the trial, it's what we think of the trial, essentially. So, conclusions, broad consistency for the core management, as you'd expect, although interesting, only exercise was explicitly advocated for in all 13 guidelines. Electrotherapies, bracing, manual treatments, a bit more inconsistency, and it's all about how we interpret evidence as to what that guidance is. That leaves us two things. That's confusing for patients, possibly confusing for therapists out in clinical practice. But the other notable thing was that we said, yes, exercise is good. No one talked about what exercise meant. How much exercise, under what context, what sort of dosage of TENS are we talking about? None of that was considered in any of the guidelines. So clinical implementation, even if we agree, is massively open to variation. And things we think are really, really simple, like the management of knee OA, actually is a great big black hole, it seems. Thanks very much.
Thank you. And then finally, if we can ask Michael Dunn to come up. Yep, squeeze it. Yep. Squish up. Yeah.
Squeeze it. Miss life, actually. You had that in your eyes the whole time.
Hi, so I'm going to talk through a conversation around who virtual care or virtual physiotherapy in this instance really benefits. Is it patients or is it service providers? And I'm going to frame the conversation around a service that we developed where we feel as though we've struck a good balance. Now, of course, we do have access to virtual options in the delivery of our normal physiotherapy intervention. But this new service that we now run is wholly virtual, and I'm going to talk you through that. So, firstly, I wanted to kind of talk about the underpinning philosophy for this service, and it's evidence-based medicine. It's obviously a concept that we're all familiar with, at least in the words evidence-based practice or evidence-based medicine. It's actually a reasonably new concept. This was only published in 1992. Before then, it was commonplace for practice to be pretty guru-led, based on their own clinical experience and informed by their own pathophysiological understandings, which led to massive variability depending on where you went. But what they outlined in this was considered a paradigm-shifting paper, and it's followed 20 years or so of research about how to integrate research into practice, because again there was always this disconnect, and there still is a bit of a disconnect, but much less so. And what they outlined is that evidence-based practice should of course include the current best external evidence. We should use that information to inform decisions about clinical care, but we should integrate that with patients' individual preferences. Shared decision making is something that we're saying a lot recently, but it's not a new idea. We've known this for a long time, that was a really important factor to include in decisions about care. But of course, lastly, we do need to include that individual clinical expertise. The clinician may well have seen patients with similar presentations before, and therefore they can use that experience to help guide the care, but again, that should be integrated with these other two factors. Now, shortly after the outline of what evidence-based medicine is, they felt that they needed to outline exactly what it wasn't, because already there was a trend of policymakers cherry-picking the best evidence bit and applying it applying it indiscriminately. So saying a one-size-fits-all approach, cookbook medicine is what they call it. Every patient gets this treatment because that's the best evidence. And that's exactly what it isn't. That's not evidence-based practice. But what happened is in 2020, we had a virtual care explosion because of COVID. All of a sudden, we didn't really have good virtual care options within our physiotherapy services, and all of a sudden it was 100% virtual. And it worked all right. So much so that a year later in 2021, our managers would come round and say, great news, actually the outcomes from the patients you saw in COVID were just as good as when you were running fully operationally face-to-face, so we can just move you out of your big gym and all of your cubicles and put you in a cupboard and give you a few computers and you can do the whole thing virtually. But that's cookbook medicine, and that is not evidence-based practice. And these are the hijackers that they warned us about in this concern that they outlined in 1996. But that being said, there are still some good opportunities to be had with the explosion of virtual care, and that's what we tried to capitalize upon here. So yes, we run, we have virtual options, but in addition, we run this clinic, and the aim of this clinic was to provide rapid musculoskeletal advice to patients, rather than them sitting on a list and waiting a number of months. The aim was to reduce pressure on our face-to-face services. Like almost all NHS services, we're overstretched and under-resourced, and if we're not using our resources efficiently, the list gets bigger and bigger. But we wanted to ensure we adhered to the evidence-based medicine philosophy, and it needed to be good for the patient and good for the service. If you make something that's good for the service but not good for the patient, like forcing a whole operation to become virtual, it's a false economy because these patients may not feel properly treated and they'll come back through and take up more resources further down the line. So it's not a good approach. But likewise, if you do something that's great for the patient but uses a lot of resource, it's not sustainable. It will get harder and harder to keep up with the pace. We used this double diamond approach to outline how we did this project development. The point of this slide is essentially to just outline that what I'm presenting today is what we do now, but this was a real iterative process with lots of mistakes that we learned from and changed, and it gradually improved upon. And what we do now is essentially this here. So we outline or identify from the referrals in our MSK single point of access the kind of ones that might be suitable for our virtual musculoskeletal clinic. I'll talk to you who those are in a moment. Talk to you about who those are in a moment. We aim to call them within 1 week or video call them within 1 week, optional to them. Again, we learnt that if they wait 6 weeks, they were annoyed. But if we did it within a week, they were really happy, even though it was over the phone or video, because it was impressive that we'd responded so fast. These are the outcomes of this phone call, and these outcomes are again based on the patient's preference and the clinician's advice as well. But it could be that they go on to self-management on a PIFU pathway. It could be that they have a one-off face-to-face consultation just to do an assessment or for some other reason. It could be that they go to one of our physio classes. It could be that they actually do go on to have the normal course of physiotherapy like they would have normally, or it could be that they go to a different MSK service. Now, the inclusion criteria that we've refined and iterated is essentially it works best for people who may be eligible for one of our classes. It works for people where it's not clear which MSK service they might need. Again, rheumatology, neurosurgery, orthopedics, physio, there's a number to choose from. And it particularly works with those who may be happy with some self-management advice, but we wanted to understand who that is better, so we collected a lot of data. Now, generally, we've got 926 data sets. About 50% of the time, we were doing something that was a good use of resources for the service, in that we were not using as much resources because people went onto self-management on a PIFU pathway. They could come back if they needed to, or they went to a different MSK service, or they went to a class. But 50% of the time, they did still choose to go down the physiotherapy route. And again, we wanted to understand who those people are so that we can be more targeted with this going forwards. This is the data that we have so far. There's a few trends, and some of them probably won't be very surprising. You can see particularly that ankle pain we tend to do a little bit better with. We've got 145 people who had ankle pain who went through this service. About 51% of them were happy to be self-managing and put on a PIFU pathway, and 43% still wanted to go to physio, better than the average in both instances. But there's a particular trend behind here, a hidden third variable that was really important, and again, we learnt this over time, is that the longer they've had their condition, the more likely they are, and the clinician is to feel that they probably need a course of physiotherapy, which is normal resource physiotherapy care. And of course, the shorter they've had their problem, the more likely they were to be happy to self-manage and get on well with self-management. So really, it turns out that that group that we're identifying, the ones who are happy to self-manage, are really just the ones who didn't get the right information, most likely in their primary care services. If they were seen by a good FCP, for example, they may not have needed to be referred to physiotherapy. But we're catching those, and it is enabling better use of our resource. There are some other trends. So if we look at ankle pain more specifically, we can see that ligament sprains particularly are better in the service. But again, if you see on the end there, 88% of those who went on to self-management were within 3 months of injury. Again, highlighting what I was saying a moment ago. So it's particularly useful for those with newer conditions. Likewise, with avulsion fractures of the ankle, you can see that 100% of those were actually happy. Within 3 months, were happy to self-manage, and a smaller number went to physiotherapy, namely ones who'd had it for longer than 3 months. We could also see that looking into knee pain a little bit more, that there were some trends. So those who've twisted their knee, but we're not sure exactly what they've injured because it's just a virtual consultation, that they were also quite happy to self-manage, but again, only really if they were in that 3-month window from onset. So what that means is those are the kind of people we particularly target. And we also wanted to make sure it was good for the patient. We don't know that these people are doing well just by the fact that we've managed to put them on a PIFU pathway. So we called them up about 6 months down the line and asked a number of them, how are you getting on? And thankfully, most of them were getting on pretty well. They considered themselves either to be better or to be self-managing, suggesting that this service is hopefully good for the patient for the most part. In addition, most of these people didn't go back to use more resources, which was again a concern that we were aiming to avoid. And also, most of these people didn't go on, initiate their PIFU pathway and come back into the service. So it turns out, as far as we can tell, that we've done a reasonably good job. Now, the point really is that indiscriminately applying virtual care without giving the option to people, like we often were encouraged to do by our managers, it goes against evidence-based practice medicine principles, and you're probably setting ourselves up for more difficulties in the future for those patients and for our services. Patient preference and clinician expertise are important, and this is just an example of a successfully implemented virtual MSK service which adheres to these principles. And that's it. If you were interested for your MSK service to do something similar, feel free to reach out to me because I'd love more data for that Excel that I showed you images of. Because you can see when you funnel the numbers down, 926 turns into nothing when you funnel it down to all these different conditions. And that's it.
Right, I'm going to hand this over to Iona and we're going to take questions. So I'm going to open it up to the floor. If we've got, okay, I'm going to get another mic. Any questions from anyone? Oh, yep, we're coming round to you shortly.
This is a question for Michael. I'm Esther Williamson. I'm a physio researcher predominantly. I was interested that one of your criteria was people looked like they'd be suitable for a group, like escape pain, but actually very few people went on to groups. Was that a surprise?
That 7% was of every single person who came through the pathway. Most of the people who come through the pathway were from the last inclusion criteria. The maybe eligible for self-management. I actually don't know. I should have done. That's a good point. I should have separated that bit of data so that I could see how many people who were specifically referred to us for query a class actually went to a class. I don't know the answer to that question.
Thanks.
Yeah, no, great presentation. It's more of a comment. I just was going to mention that I think it's really nice to see the link with digital to actual something that's tangible in clinical pathways, because I think often we talk about digital in terms of quite non-specific and general competencies, but actually you're kind of demonstrating there it's linking into the clinical triage. So yeah, not a question, just a comment, but yeah.
Thanks very much.
Any other questions? I've got a question, if I may. Just in terms of next steps, you know, if we were going to take all of your learnings into, you know, our everyday practice, what would you say? What would be the take-home message? Should we start at this end first?
Yeah. Well, obviously we're now, the data that Mal and I presented along with the other work packages are part of a new intervention development. I suppose if we look at just the data that Mal and I presented, it's a joining up of the information, the information that moves between clinicians and patients, but also the information that moves between clinicians, and making sure that we tighten up those gaps that patients appear to be falling down, so that everybody's singing from the same hymn sheet. I don't know, Mal, if you want to add to it.
I think it was the communication aspect was very, very evident, wasn't it, in both the patient data and the HCP data. So yeah, I think you summarised that.
I suppose mine would be that the way we manage after joint arthroplasty is changing. You know, far more is now done as day case surgery or very limited length of stay. We don't have the resources to see every single person in the old traditional model of face-to-face physio. So I think it's important that we both explore who it is who really does need our help and who can probably have the resources to self-manage, and whether that is face-to-face or by virtual means.
Yeah, I think a sort of general observation is the frankly amazing variation in clinical practice. I work in knee MSK and orthopedics and have done for about 20 years now. And you'd think knee OA and knee replacement and care after knee replacement is the same. And the lady has been talking about some of the trials, and trials have been done in knee OA and knee replacement. You can't recruit certain sites because to deliver physiotherapy in a trial setting, oh yeah, we do that, but we do it totally differently. We can't come on board with your protocol and the way you're delivering it for your trial. So something seemingly simple, we all do the same stuff, but totally differently. And I think that leads to your first point, and that sort of practice variation is confusing for patients, frankly. And it feels like we should be able to tighten it up somehow, because it is all the same stuff.
It is, absolutely.
I suppose I think I got across my key points in the talk, but the main thing for this to be able to happen was to have a supportive leadership team. Within our department, because I think we've got lots of digital opportunities available to us now, but how much time do we actually have as clinicians to actually play around with them and find innovative ways of employing them in a way that work? This took about 3 years of iteration. And thankfully, the physio consultant who runs our department just wandered in, probably expecting my talk to start now. But the reason we were able to figure out a way to make this work is because we were given the freedom to make errors and to learn from them. And I think that's something that we perhaps need to get a bit more comfortable embracing, and providing clinicians those opportunities to play around in practice.
Any other thoughts, comments, questions? Stunned silence. I think for me, just listening to all of this, I often hear from patients saying, I think it was yourself that said around the quote where one person says, one physio's told me this, and then they come and see another physio, and then they're told something else. And then that's when they start to mistrust us. And so I think the more we can sort of try and get better at our communicating, and that's going to go a long way for our patients, because it must be, it's confusing to us that we don't even know what we're recommending. How can our public know? So yeah, I think a little bit of anything we can do to improve that is good. Anything else? Otherwise, you're all keen to finish early today.
Everyone wants a beer, I think.
Yes, is that what it is? Okay, well, as no one else has got anything to comment, thank you very much to all of our speakers. They've really got my mind thinking, and yeah, really appreciate it. And I'll let you all disappear